Good day. This is the first in our series of lectures and demonstrations on the South African maternity case record, and in this case, the introduction to the new updated maternity case record. And in fact, there's two booklets. The maternity case record itself that contains all the notes related to the antenatal, intrapartum and postpartum care, and then the perioperative record, which is only used if a patient needs a surgical procedure. And this one contains the consent forms, the anesthetic forms, and forms related to sterilization or hysterectomy if that's indicated. So most patients will only need the maternity case record, and they will only need to get the additional perioperative record when they book for surgery, and these records can be inserted into each other. So the perioperative record is inserted into the maternity case record for filing purposes after. All of the information that is in the new maternity case record can be found in this guide, the Intrapartum Care Guide in South Africa. It's an updated guideline from 2019, published by the Medical Research Council, University of Pretoria, and it is available online. In turn, this is based on the World Health Organization Intrapartum Care Guideline, which was updated in 2018. And it's called Intrapartum Care for a Positive Childbirth Experience. This contains all the information that you need related to antenatal care. It's a very comprehensive and updated guideline and can be downloaded also for free from the internet. So this is the front page of the maternity case record, and you can immediately see it looks a little bit different than the previous version, in that the level of care has now moved to the front of the record. So that whoever attends to this patient first can see immediately where she needs to go for antenatal clinic and where a delivery site is and what the arrangements is for transport when in labor. And make sure this is always updated, because the level of care can change as the pregnancy progresses. So a patient might need to go to a high-risk clinic or might need to deliver at a specific level of care. The rest is just the women's details, so a large patient sticker comes here. When she's mum connected, it can be ticked there. And then name, ID number, contact detail of mandate, and name of birth companion. All of this can be on the front page. So it's important to realize that the patient carry their own case notes. It's very good because then the notes are in the patient's possession, and when she moves to another province or another health facility, or she goes private, she takes the information with her, and there's never loss of information. And this is evidence-based. If you look at the Cochrane database, there is a review on giving women their own case notes to carry during pregnancy, and a number of studies have shown that women carrying their own notes were more likely to feel in control of their pregnancy. They wanted to carry their own notes in a subsequent pregnancy, and the risk of notes that gets lost or left at home is not significant. There is no difference for other health-related behaviors, depression, miscarriage, stillbirth, or neonatal death. The maternity case record was developed and updated over the last few years, specifically 2018 to 2020. This was a National Department of Health initiative, with multiple input from various organizations, committees, and they're all listed there. So it's the Ministerial Advisory Committees on Saving Mothers and Saving Babies, the Medical Research Council, the Midwife Society of South Africa, the Obstetrician and Gynecology Society, lots of clinicians from all the provinces, experts from the World Health Organization, and you can see the PMTCT, nutrition people, primary care stationary people, maternal mental health. All of those people were involved in the update. So what has changed? I've shown you the cover page that has changed. There's much more information for patients in the book. The screening for mental health care has been added. There's more space for notes, so the 8 Bank Plus visits each have their own block for notes. There's updated HIV and PMTCT information. The antenatal card itself is updated. There's now also a duplicate of the antenatal card, so a carbon copy can be put in and a copy can be removed to stay at the primary care stationery, so there's again no loss of information. The early warning chart has been updated. I'll show you copies later. And right through the whole document, mental health and respectful care prompts have been added to conform to the respectful care in pregnancy module from SMOE. A fetal kick chart has been added. There's space to add basic ultrasound reports. There's a new observation chart for doubtful labour. There's a new interim partogram, and there's a separate video demonstration on the partogram, and there's also a separate partogram exercise that you can do. There's space to document cardiotocography, and again there's a separate video on CTG, how to interpret and how to document it in the maternity case record. The summary of labour page has changed because there's a new definition of the second stage, and I'll come to that. The shock index has been added to the page on postpartum observations. The Robson classification has been added for cesarean sections. There's now more space to make puerperium notes. There's a pre-discharge safety checklist that's been added, and there's a new discharge summary. So let's go through this in a little bit more detail. In front of the book, there's a pictogram on danger signs in pregnancy, and you can discuss this with patient at the first visit, and they can read it with subsequent visits, and you can see that it says I've got a headache, my hands feel stiff, my rings are tight, my feet are swollen, so that could be preeclampsia. And similarly, there is I am unable to stop worrying, I feel down, depressed and hopeless, I think about hurting myself, mental problems, depression has been added. So patients can go to the clinic if they experience any of these, and it is there for information. Similarly, on the back page, there's danger signs after delivery, and this includes postpartum depression, pulmonary edema, hypothermia, so there's lots of things that can be added. The patient can read during pregnancy for after delivery. In the latest version of the booklet, this page can be detached after delivery, and the patient can take it home, so she also has this information with her. Then there's a screening tool for mental health added. And this is just based on 3 questions. In the last 2 weeks, have you on some or most days felt unable to stop worrying or thinking too much? The same, have you on some or most days felt down, depressed or hopeless? Or if you had plans to harm yourself or commit suicide? And these are scored yes or no, and if there's 1 tick, we can manage the patient at the clinic, but 2 or 3 ticks as referred. And just refer to the next level of mental health care, so whether that's a mental health nurse or a social worker, psychiatrist, or whatever you've got available for referral for mental health. Evidently, if there's a self-harm, then she needs urgent referral to a psychiatric service. This screening tool was developed and validated specifically for our setting. And if you want to read more detail about this, then you can read this article, and the reference is there on top. There's also some information about family planning added for after the baby is born. And this is on the back page, and the patients can read through it. You can also use it when counseling the patient about effective methods, and all the information is available. This is the new antenatal card. And as I said previously, there's 2 copies. You can put carbon paper between them. The 1 copy is perforated. So the one stays, the original stays in the folder, but the duplicate you can tear out and keep in your primary care stationery, so that there is duplicate of the information. Most of this was on the previous version. What has been added is the mental health, more information about mental health, misuse of herbal medicine and over-the-counter drugs. There's more space for HIV test and retesting and for viral loads. The mental health screening that you've done on the previous page, that score gets put in here. And then there's lots of information about counseling, danger signs, HIV, alcohol, tobacco, substances, and 2 occasions where you can document counseling. And then there's future contraceptive plans. And you'll see right through the document that there have been prompts added, all management plans discussed with patient, for example, education material given. I've introduced myself by name to this patient to make sure that the care of pregnancy is respectful and dignified. So similarly, in the place where you make your Bank Plus notes for each visit, the respectful care prompts have been added. So I've introduced myself by name to this person, and I've explained management plans and checked that she understands. A fetal movement chart have been added, and examples I'll show them now how to complete it, just the ticks for each day of the week. But there is a caveat, it says only when indicated. And we know that there's no universally agreed definition of reduced fetal movements, and there's insufficient evidence to recommend formal fetal movement counting using specific alarms like 10 or 5 movements a day. And also that routine counting may do harm. I'll show you a study just now that showed that there's an increase in neonatal deaths and more cesarean sections and more maternal anxiety when routine counting is done in low-risk pregnancies. So at the moment there's insufficient data from randomized trials to guide practice. The one positive thing is that it affects maternal fetal attachment, bonding. So selective fetal movement counting with suspected fetal compromise is recommended, but we still need studies. So this is the AFFIRM trial, which showed that routine counting of fetal movements in a low-risk pregnancy, which is otherwise uncomplicated, leads to a higher number of post-neonatal deaths. So again, fetal movement counting, only do that or recommend that when there is a specific reason to worry about it. This space for basic ultrasound report is actually 2 copies of this, so if the patient needs more than 1 ultrasound, there's a space to document both of those. If she's got a printed report, then it can just be stapled to this page. This is the new graph that's been added, and that is for doubtful labour. So if a patient is admitted with query false labour, query latent labour, and you're not sure, there's 2 places, 2 assessments to be done about 6 hours apart. And you can read the fine print. It's all the maternal observations, the fetal observations, the vaginal examination, and then the checklist is the mother conditions reassuring, there's a fetal condition reassuring. And 6 hours later you can repeat that and then make a plan. If there's no changes since admission and all the conditions is reassuring, the patient was in doubtful labour or in false labour, and she can discharge and follow up routinely. As I said previously, the early warning charts, which you know by now because they've been used for a few years, they've just been split into antenatal and postnatal cards. So the aspects specifically relating to antenatal care, like the fetal heart rate, antepartum hemorrhage, those are on the antenatal early warning chart. And it's still used as before. Observations are plotted. If one observation is plotted in red, the patient needs urgent review by a doctor or a senior midwife. Similarly, if 2 observations are plotted in yellow, it's the same as 1 red, she needs review. So it does say the total yellow score, total red score, doctor called yes or no. And that's the whole idea of the early warning chart, is that you pick up on abnormal observations and review the patient. Good. For the assessments during labour, that's close to the partogram. Again, the respectful care prompts have been added to the pre-existing form, and just make sure that you complete every time you do an assessment during labour. There are a few pages using the FIGO 2015 classification for CTGs, where you can document CTGs. And as I said, there's a separate video that you can watch that shows you how to interpret the CTG and how to document it in this. And this is only used mostly in hospitals or where there's high-risk patients managed with CTG. The second stage definition has changed somewhat, and you'll see that in the Intrapartum care guide that I've referred to, in that there's a difference between full dilatation and bearing down. Once this patient's cervix is fully dilated, it may take 1 to 2 hours before she gets the urge to bearing down. So there's a separate place to document the active phase of labour, and I'll come to that, which starts at 5 centimeters, and full dilatation, and then when she gets the urge to bear down. And from the urge to bear down is when we start counting the second stage of labour. A little prompt has been added about the situation on the labour ward, and you can use your own ideas on what you want to add here, but this is aimed at a place where the labour ward is suddenly extremely busy, You don't have enough beds, patients are delivering on the floor or in chairs, or there's midwives absent from duty, and you can just write the situation in labour ward at the time of delivery. In case in a year or 2 or 3 you need to go to court for a specific reason, then there is a documentation on how busy the labour ward was at that specific day that you did this delivery. As I said, the classification of shock, this page used to be in the maternity case record, but the shock index has been added. It's highlighted in black. It's just easier to calculate because you just basically divide the heart rate by the systolic blood pressure, and the normal should be less than 0.5. So if it's anything higher, the patient is in shock. And this is on the page for postpartum observations, where you plot the observations directly after normal delivery or cesarean section. This is just to show you where the Robson classification has been added. So if the patient had a cesarean section, just tick one of these boxes, and that makes it easier if you do audits of cesarean sections to see which Robson criteria was used for the decision. And again, it's just a tick to say that information has been given to the patient and consent has been obtained from the patient for the cesarean section. The rest of the notes looks as it has before. This is the postnatal warning chart, and again the same as before, 2 yellow observations or 1 observation that plots in red needs review by a doctor or an advanced midwife as soon as possible. This is the pre-discharge checklist, especially where mothers are discharged within 6 or 8 hours after delivery. You have to assess the mother, and if there's any block that ticks yes, there is a recommended action, but that patient should stay and be evaluated by a doctor or by an advanced midwife and managed appropriately. So it has to do with danger signs in the mother, with the bleeding, and with the vital signs, with urination, with the mental state, and then also if the baby has got any problems or has not been breastfeeding. So if any of these checks is yes, look at the recommended action and manage the patient appropriately. If the pre-discharge checklist is clear and the patient can go home, this is the discharge summary. Again, it can be done in duplicate. It looks busy, but it's just a tick. You just put in type of delivery, normal, HIV status, syphilis, rhesus, any problems during pregnancy, and there's space for 2 babies, and then advice on discharge, and the patient can take a copy with her home. This is how the new partogram looks, and you can see the main difference from before is that according to the World Health Organization and our updated Intrapartum care guideline, the definition of the active stage of the first stage of labour is at 5 centimeters fully dilatation and fully dilated cervix. You can see that the active phase starts at 5 centimeters, and there are still 2 lines 2 hours apart, but all of this is explained in the video on the partogram and the Intrapartum care. And just to end, this maternity case record was extensively piloted, and all the feedback from the pilot sites we included in the updated version, and it keeps on being updated as we go along. But at this stage, it's a document that you can use, and you can refer to these lectures and demonstrations to help you to complete the document. Thanks.